when someone comes to the front door of your respite, when do you say no? I hear from all of you that the most important thing is to say yes as much as possible. But are there times when you say no? And if so, who gets to say no? That's open for everybody.
I can count on one hand how many times we've said no. We really don't. So it's, you know, we do a pre-registration with everyone. They call the house first and we ask them, you know, how we can help them, what they need and whatever. Every staff person is trained to welcome guests in. So there's nobody, you know, at the higher levels or anything making those decisions. If it is questionable, then we will, you know, move it up to a supervisor, just to have a discussion around it. But we really not had the issue of having to say no to folks that have come in.
I would say similarly, like we often do not say no, and a lot of our peer respite advocates, like they usually reach out on a call, they talk to the person. I saw in the chat someone had a question about accessibility needs. We usually talk about accessibility needs when a person's first coming to us, and I think usually from there we're able to determine how best we can support that person. But yeah, more often than not, we don't say no. I'd say if there were circumstances, it would be if it were like medically impossible for us to like support someone in the space in the ways that they needed. We've had a couple occasions where it was like someone needed a nurse on standby 24 hours a day, 7 days a week, like in the space in that way. And we weren't able to offer that level of support.
And very similarly for us, it's a shared decision. It's not a hierarchical decision. And it's based on a lot of things like space. Is this the environment that actually feels safe and healthy for you? Is this a comfortable space for you? You know, sometimes people come and they don't know what it is. They're looking for a clinical support. Or they're looking for something else. And that's okay, completely valid. We want to support you to get the support that feels right to you. We have very few people that it's not the right fit or doesn't feel like the right fit. So very similar to Steve and to Vesper, it's very, very rarely like a no. In terms of the accessibility question, for us, we have widened several doors. We have an accessible bedroom. We have an accessible shower and whole bathroom actually was designed with folks that utilize wheelchairs and came in, helped us design it. We had disability rights come in and do an evaluation of our space and give us a report and recommendations. And we modified everything that we could modify in an old house to make sure that it was accessible, including a ramp and things like that.
Incredible. In a system where so many of us hear no, right? No, you don't qualify. No, we don't have space. No, this isn't the right fit. No, you don't have the right thing written in your chart somewhere that you may or may not be able to see. To hear all three of you say, we say yes. You know, like as much as possible, count on one hand of the nose. That is just such a shift and really, really powerful. On the heels of that, so one of the, I know as we look from a systems perspective and crisis services, there is this idea that sometimes choice goes away. Often choice goes away and it's taken away from folks. We know also if we look at all the systems of oppression that impact people of all identities and why and how that happens. But one of the gleaming pieces of peer respite is the idea that it's voluntary, it's choice-based, that folks, you know, are able to say yes to that you create safe, empowering spaces. And in some of the research about, you know, focuses on rehospitalization or being able to divert folks out of involuntary or coercive environments. So can you talk about, have there been times when someone has started to be caught up in a situation where their choices are being taken away and how the peer respite has created a voluntary environment? Because I think there's a big question about what's that moment and when can you move into a peer respite instead of having to go through this often very traumatizing experience of not having control over where you're going or what's happening to you?
I'm going to give grace to whoever would like to answer first. Steve, would you like to go?
The question you're asking is, does the respite take some of those freedoms away?
Oh, I'm so sorry. That wasn't
Or-
me being clear. How and when can the respite become involved with folks who maybe the law enforcement showed up in response to a concern, and there's that thought of either we're going involuntary or we're making voluntary? How does your peer respite interact with law enforcement or the judicial system in any way to create a pathway into the respite? I apologize for not being clear. Does that help?
Oh, yes, yeah. It's very simple, actually. I mean, that's what I mean about the community understanding who you are and what you do. They start to understand the criteria in the community. So the officers all clearly understand the criteria of the house, and they can say to somebody themselves, look, I could do one of three things. I can arrest you, which I don't want to do. I can bring you to an emergency room, which I really don't want to do, or I can bring you to a respite. So it's your choice. So they're still giving choice to the individual, and I'll tell you, 10 times out of 10 it'll be the respite when they're being engaged in the community. The same with if they're in clinics, or if they're in traditional services and they're starting to ramp up in whatever it is going on for them. They're given the choices, and they're given the understanding that this is completely voluntary. Again, the de-escalation is volunteering. The de-escalation is support and being embraced, and supported to come into the house. So it doesn't become as big an issue, I think, as most people would think it could be.
We've started working on a community policing response. So we work with the local police departments. Usually they know about our respite. Sometimes they'll be like, okay, I'm going to put in a recommendation for a mobile with a person, and we will meet with them sometimes instead of that same response. We are building it out more. Massachusetts, I find, as a commonwealth, is a medical hub. So there's a lot of inclusion of clinicians, social workers in the response, and we're constantly advocating, please include more peer supporters. Please include more peer supporters. So we are getting there, and we are seeing it, but we are still in the implementation process, if you will.
And I'll just add another layer to that, in addition to what both of you have shared, and that's guardians. So we have a lot of conversations with folks that want to come, and they have guardians. They're living at home with a family member, and they're wanting the freedom to be able to come to a space like this rather than end up going to a respite. And so we've had many, many conversations with the person, with whomever they find to be their support, whether it's their guardian, whether it is a clinician, whether they are police involved, whatever the case may be. Right, there's fear that people have when somebody chooses an environment like the respite, and so we have to demystify some of the fear and assuage some of the fear, so that people also feel comfortable that people are coming into a safe space, and that we value and honor their safety in addition to valuing and honoring their freedom. In terms of police involvement, the respite is a part of CIT training. And so police officers absolutely are connected and know about it. One of the things that police love about us is we never call them. We are, as an agency, are a zero force and zero coercion agency. We do not call police to come and intervene unless it would be absolutely an unusual situation, because our job is to literally support people through distress. That's what we do. And so the police love the fact that they're in an environment that they know we are going to be there with people and help them work through it. And we are not just going to call the police to come and intervene when things get difficult.
Thank you all so much. Those were like such concrete examples of how the kind of what we may take for granted as the sequential intercept, right? Kind of like, well, once you start this process, it just keeps going, and about all those opportunities that come from the, whether it's the hospital, the emergency room, the mobile crisis team, the CIT teams, the police officers, the neighborhood, everybody understanding what does a peer respite do and feeling comfortable and confident in making those connections. So that speaks, I think, to the need for really strong community engagement. And as we're going around, speaking with stakeholders in Carroll County and Howard County and Baltimore City, it's also understanding in each environment. Vesper, I really appreciated the way you talked about the peer respites being very grounded in what does that local community look like. I know Cherene, in some of the conversations that we've had, you've talked a lot about neighborhood and neighborhood engagement, just that's a huge piece. And I would like to talk more about that as we move up into maybe operational questions. But one more sort of on the ground, someone who is in the respite and maybe they are experiencing a lot of barriers. They don't have housing, or their housing's unstable. They're dealing with medical or physical health or disability, and maybe not getting all the support that they need. Maybe they don't have enough clothing or food or their vital documents. Can you talk about how you're, at an organizational level, how do you make sure that your respite is well connected with the services or the supports that people might need? To your point, Steve, earlier about, I wish people asked what happens when folks leave the respite, like having those successes of creating that pathway back into health and home and independence and community. So how do you operationalize that?
To grow. Oh, go ahead, Vesper.
Yeah, I mean, it can be rough though. It's it's hard sometimes because I think it's how engaged the person wants to be after they leave the peer respite, if they want to continue to receive those resources or not. And what I was going to say was that we sponsor 7 community fridges in the city of Worcester, and we're building more community fridges in Southbridge, and we're building more community fridges. And if you're not familiar with what a community fridge is, it's a refrigerator that is generally outside, that is sponsored by an entity nearby that can keep it powered with electricity and all of that. And we stock all of those fridges with food. We also have community closets in all of our recovery learning communities. We have a peer bridger that meets with the person if they would like before they leave the peer respite, so they can continue to be connected. And we always offer mobile for those resources. We're also working on a trans closet. So if people need binders, breast formations, or need to get on hormones and need to work with a peer supporter in order to get there, then we sometimes provide those things directly, or we're able to recommend them to someone.
Yeah, I would just add to that my organization, we have well over 120 employees now that are in different levels of service. So we have mobile, we have forensic mobile teams, we have regular mobile teams, we have recovery staff that are just out in the street. So we have care coordination now. We also provide housing. We have over 200 units of housing, and we're building housing as we speak. So it's, the respite creates some interesting opportunities, when you start to step back and see where people are really struggling. We're tied into the FQHCs, all the food security agencies, all the shelters. It's how well you build your infrastructure of your organization that's going to serve the people once they leave the respite. And so nobody gets left behind, in our organization. And we are strong advocates for constant change and improvements in the system itself, from us right up to the governor. So we're knocking on every door trying to make it better for everybody.
So from a big picture answer, there is a combination of building out your continuum within your organization to making sure that people have access and supports in a variety of different environments. We have an outreach team that works in street community, in encampment sites. We have a forensic team that works on diversion, reentry, going into prisons and jail, but prevent incarceration. I can go on and on. We also have 130 employees at PRN with a variety of things that we do. So that's building out our own continuum within our organization that is accessible to anybody. And then, Vesper, as you're talking about, I think one mistake would be to think about a respite as a discrete program, not a part of a larger community, right? You have to be a part of community. There are other resources, supports, efforts, movements, grassroots things that are going on within your community that you want to be a part of the fabric of, not just a discrete program that is doing something over here. And so any way that we can contribute to our community, like the fridges, like Narcan distribution in making sure that those are available in a variety of environments, like needle exchange, like food insecurity and supporting homegrown healthy food and access to those things, and then connecting to a larger community of services and supports, it is really critical that a respite is a part of a community, not just discrete from it.
Thank you. That is a charge out, and really speaks to, I think, work that I'm glad GBRICS, the GBRICS project in Central Maryland, that is trying to create a regional, or is creating a regional crisis system, understanding that just because you walk 2 miles that way doesn't mean you should suddenly lose access to services or gain access to services. The work at the state level of understanding, you know, how are we making sure that our system is well connected, and specifically though thinking about data, to your point, Steve, about being strong advocates for the expansion of peer delivered services, peer run services and alternatives, and all of that requires funding. How do you all use documentation and data to prove the case for peer respite, for getting that buy-in, for being able to illustrate the impact that you're making? And is there anything you don't do around documentation or data that you think would be surprising to maybe folks on this call or folks who watch this video later?
The thing we don't do is we don't care about diagnoses, that's for sure. We care about the individuals that are in front of us and who we serve. And as far as data, you want to show the efficacy of the service you deliver. So we work with consultants nationally on building those outcome, data points, so that we're measuring, is the like quality of life. We're not just looking at, are we reducing crisis? Is the quality of life changing? Is it getting better? We're also putting our funding into research and evaluation. And then we have a quality assurance department as well that looks at the quality of care and services. So we're doing the surveys, we're getting the testimonials, we're doing everything that Vesper and Cherene are also doing to ensure and gain the credibility and the respect that we all deserve in what we've created. So data is very important to us.
It is very important. Otherwise, it feels like theory and like a really nice thing to do, but not practical or safe or effective. And so I think we all have to, Steve, Vesper, myself, all of us that are in the peer respite community are always having to find ways to validate, justify, but also tell the story and tell the reality of the story. I'll tell you some of the things we don't do around data. We do not do any assessments. We do not require referral. We don't do clinical assessments. We are not interested in diagnosis. We don't do level notes. Things that feel clinical in this type of environment are not what we do in this environment, which is really, really important as a part of this. We actually also go insofar, and maybe both of you all do this as well. When somebody comes into the respite, there is space to be and decompress and to orient. We are not doing paperwork on the front end unless somebody wants to, but if they truly do not want to, we will get to all of that. That's not what drives this environment. What drives it is that you are in an affirming space, you're in a safe space, you're in a comfortable space. You can begin to even ground yourself in what is happening in your body, in your mind, in your life, all of those sort of things. That doesn't come in the paperwork. The paperwork will come, but we are not paperwork heavy in any way, and that is also very intentional.
I think just to add, we follow a community co-authoring model of documentation, which is basically the information that our community wants to be the narrative that is told by the survivors is what we use in terms of information to continue the growth of peer respites, to tell the stories of the people who are there as much as they would like, right? So I think what's what's important, and I had mentioned this more in depth in my keynote, is this idea that we need to reclaim this idea of like information being collected about us, and instead, what narratives do we want to tell to kind of change that paradigm, that idea that we have about information collection. So for us, often we will sit with someone like, what is the story you do want to tell? Like there is no pressure here, but like if we're doing a study, if we're working on something, right, that's so important. And I'd say that the only data that we usually collect is from like when someone's like, oh, you know, this is the neighborhood I'm coming from geographically in Massachusetts, or like, or, you know, if there's any demographic information, it would be what they are comfortable with disclosing. And the only reason why we collect that is for purposes of affirmative action. Because if you don't know, like, what communities you are supporting, if the community you are supporting is predominantly white, if it is predominantly you know, men versus women, if it's predominantly many of these things, it's like, how will you know that unless if you take an evaluation and a look at yourself? How will you take that action to change, to do better, right? So for us, it's, again, how much a person is comfortable with disclosing, and usually we're very transparent about, like, we're working together on this.
And I want to just add one more thing. In all of this, whether it's a data question, a safety question, a how people come to us question, peer respites are about access, right? So many environments are not accessible to people. And we have to be really considerate of the barriers for access that people have had throughout many years of service involvement. And that barrier could be a referral barrier, it could be an assessment barrier, it can be a I have to share information about myself that I'm not comfortable barrier, or these people have to know I'm here barrier. Whatever those barriers are to access, we have to be very intentional and very cognizant about, and try to find that yes, which means that we have to be as low barrier as an option as we possibly can be, because frankly, there are not many other low barrier options available for people that are experiencing crisis. So we have to embed the yes into how we operate so that people feel comfortable coming and engaging.
Embed the yes. That's a bumper sticker right there that we can probably apply in so many ways to what we're doing everywhere. On the heels of that question, being able to say yes also means having the resources to do that, to not be beholden in different ways, so that you can run your programs, but also create communities that are responsive, that are mutual, that are collaborative, and that are effective in healing. Can you talk a little bit about how your respites are funded, or maybe considerations for how you sit in the system, that demystifies that aspect of how do you make such an accessible alternative that should be the mainstream for supporting people?
So I'm going to say something that might feel a little bit unusual. Some of you have heard me say this before, but we turn down more funding than we accept as an organization. And the reason for that is because all money is not good money. I see some of you like, what? All money is not good money. We have to be very cognizant about what we are exchanging for funding. And if what we are exchanging for funding is the integrity of peer support, it's the integrity of a respite model, it's the ability to have accessible space, it's the co-creation environment. If we are giving that up for funding, that is not something as a CEO that I'm willing to do. So we are looking for funding partners, not just funding streams. So that's one, again, another thing that I just need to name as far as we are concerned. Our funding for our respite comes from our county. We've had a long-standing relationship with our county that funds a variety of different things, and they fund it because they truly value it, and they know that we need this in our community. Other respites, well, actually, I'm going to because we're all three funded a little bit differently. So I will just stop and say, we are funded by our county, philanthropy, contracts, technical assistance, consulting. We're always looking for a variety of ways to bring in our funding so that it is flexible.
So I'll say that we were originally funded by the state of New York because they didn't know what they were funding, and that was good. And then we got counties to pony up and start to pay for the other facilities that we had. We also did get foundation dollars. However, the respite was embraced by the state of New York Office of Mental Health, and that's dangerous because they wanted to license it. So the only thing I could do is work with the state of New York on building the license for respite. And what I infused into that license was the power of the peer support, not losing that. And I hired a consultant to come in also and said, I want to be treated like a third grader to understand what I have to do to create this unfortunate medical model so that it can still maintain the integrity of peer services and be completely peer run. And we did it. And so now the state is licensing these and paying for these, which is, unfortunate. It's not where I ever wanted to go. But if I didn't get involved in it, the state would have just bastardized it and it wouldn't be anything close to what it is. So at least we can maintain that integrity. And then through our coalition in the state, we are in touch with all the peer respites that exist now so that we work with each other on maintaining that integrity of peer support, of true peer support of what it is. And if what it is allowing us to do on the other end of it is now I'm buying more houses and building more respite. So I'm using it for the good that I can figure out on what good can come from this. And it's allowing us to expand in those areas. But it wasn't something I constantly fought the state and saying, please don't license this, please don't. And of course, they did. So it was a battle. It was really hard, but I think we did pretty well in maintaining the integrity.
Yeah, I think it's always a challenge. It's always a challenge when it's funding. I agree, both Steve and Cherene. It's really like it is building a lot of these models embedded into state funding or other sources of funding. I'd say in agreement, Cherene, that we do not accept dollars unless if it is pretty much on our terms. Our respites are funded federally. The funding is awarded to the Executive Office of Health and Human Services, and our respites are funded as Model A blended capacity respites in the Commonwealth of Massachusetts. What we have done is that in our master service agreement, what we would do, right, versus other clinical entities is variety is extremely different. So like word for word, we said, we will not be trained to administer medication. We will not collect this type of information. We will collect this type of information. And then it was basically like that master service agreement. Every time we add onto our respite model, it's already built in. All of our values, everything in a signed contract document. So as we continue to expand. Now, we have had some new opportunities. We got some private investors who are looking at home properties for us, and then we are renting from them at a certain rate. So that is what we've been looking at in terms of expansion. We've also been looking at foundation dollars, private foundations that are looking at funding us in part. And I think the reason for that is always diversify your funding. It's so important. And don't let it all be state or federal. Definitely allow there to be portions that are private endowments and otherwise.
Yeah, in other states, just so you all know, there are mental health block grant dollars and or substance use block grant dollars that will pay for peer run respites. So if we look around the country and we do a scan, which is what we're doing and we're going to put in the report, obviously funding is part of the question, is how are other peer run respites funded? And we are going to add that section so that you can see what it looks like around the country.
Thank you so much. That's for thinking about, what is peer respite? How is peer respite? Why is peer respite? These are the pieces, the building blocks of creating this. On that too, resources are certainly not just dollars and cents. The most important resources are people, right? People every day who have the training and the skills and the passion to work in a peer respite and create that transformational healing experience. Could you all talk a little bit about, I think maybe 3 aspects of this? One is you all alluded to the importance of training, of training of peer support specialists. And are there any particular considerations around training that you'd like to highlight, or you want people in Maryland to think about? The second is the question of certification. I know every state certification looks different. And there are lots of conversations happening about that. So especially to that idea of when you have a contractor, you're being licensed, or you're dealing with the sort of logistical paperwork dynamics of this, how do you conceptualize or consider the idea of being certified, whether it's certified in peer support or certified in any other type of program? And then the third piece of that would be, how do you make sure that your employees are supported the way that they need to be too, because we're all in this together. So 3 questions, kind of training, content, what you'd like to highlight, certification, how does the role of certification, what does that play in your organizations? And then thirdly, about workforce, how do you recruit and retain and support the folks you need to be able to create such wonderful programs?
Well, I can say this much. First, we certify peer specialists in the state of Massachusetts. We've done that for a long time. I think there's a lot of controversy in general about the professionalization of peer support as it exists, as it does, all of that. I think you actually need both. You need informal peer support trainings, if you will, and professional peer support trainings, if you will. And again, that's thinking of the entire concept of professionalism being rooted in racism and a variety of other things simultaneously. But I say that also because these models of how it looks to be a certified peer specialist and work on an inpatient unit, what it looks like to be a certified peer specialist who's kind of working in the middle of a police situation, right? Navigating all of these different spaces and having a training that speaks to the history of movements, peer support, and all of that is so critical. And that's what our training provides. But I'd say in addition, people take a variety of trainings, whether if that be, our trauma-informed peer support training. We offer living with suicide training. There's also alternatives to suicide training and hearing voices training. There's also intentional peer support training. I train intentional peer support, and that's such an important model. But I think for us, we have a list of trainings, and then people kind of choose their path. Because some people prefer to do wellness recovery action plan and work in that way, and some people are more like, okay, it's more about the connection, the worldview, and how we're working together. And then circumstantially, if you're trained in both, it might be different in each situation. So that all of that's to say that we have trainings that prepare people for certified peer specialists if they want that to be their path. If they don't, there are other trainings they can use. Yeah, I'd say that's us on training.
Steve, you want to go for it? Want to talk about training, and then I'll talk about training?
Sure. A lot of training. We subscribe to Relias training for the basic OSHA and safety and all that, onboarding training that needs to be done. We are certified peer specialists in New York State, and we are the curriculum writers as well that have designed the certification in New York State. And then we had to develop our own respite training itself, which I use worldwide, but on how to train staff to learn how to listen, how to engage, how to, just really how to work in the house safely. And then there's a whole safety component in there. When I say safety, a wellness component really for the staff, because, they're working in a critical environment and they need to be supported. And so our agency is extremely supportive of all staff. We have very creative staff that create different types of strategies for the houses, for the mobile teams, for, you know, wherever the staff are working on maintaining that wellness. The open door policy is here, of course, for staff to, you know, decompress if they need to, or talk about their situation or their circumstances. Just a lot of training that goes on. And then there's some traditional motivational interviewing, just to understand what that is and how that works, you know, the intentional peer support, the recovery action plan, you know, trainings, all the good stuff that came, you know, out from Pat Deegan and everybody is here as well. So it's pretty constant, you know, for the staff, and then refreshers as well, so that they stay, you know, up on all the current trainings and things.
All the same things, all the same trainings. I'm just going to add a couple things. Any willing person should not work at a respite, right? So I say to people, just because I have hands, I should not be a surgeon. Just because you have a diagnosis does not mean you should be a peer supporter. But unfortunately, as peer support has grown and training has become a little bit of wildfire in certain states like mine, we have 14 different training curricula in my state alone, 85 different trainers. It is unfortunately becoming any willing person can become trained as a peer supporter. What that does for us as a peer run organization is we have to support people to unlearn, we have to retrain, we have to untrain, we have to be very intentional about who is employed. While we operate 18 different programs, the respite is is its own thing. And not everybody can be in a space that people are coming in experiencing crisis, number one. That you can find that balance and not try to fix it, minimize it, or explode it. That you can validate and sit with somebody else's distress. Like all of those things need to be considered, right? I am a high energy person. You don't want me working in an inpatient unit. I promise you, you don't. And so my caveat to all of this is there's a ton of training that we do, all the same ones, from intentional peer support, all the way through Hearing Voices Network, all the way through Alta Suicide, all of those trainings we require of our team members. And there has got to be the right fit for this type of environment, and not everybody is a right fit, and that is completely okay.
I think what, just to add on to that, is that we had to develop characteristics of the staff we need for the different services that we provide. Because I was one of those people when I first started 24 years ago, if you said you were a peer, I hired you. And I was like, oh boy, was that a mistake? So, you know, you have to build those characteristics into your interviews and what your expectations are of your staff.
Phenomenal. I know that's, I see a lot of nodding heads, and there's certainly, that's with the expansion of the peer workforce in so many ways, and the recognition of how critical it is for people with lived experience to be embedded in every level in the healthcare system, whether or not peer is part of your job title or not, to be really human driven. It brings up these great questions about what does that mean, and how are we a number of the things you talked about, being transparent, being mutual, being honest, focusing on choice, making sure that that we can speak, this is what this looks like. Do you want to be here? And if not, that's okay. And if so, that's okay, right? Like all paths are working out. To that, I have seen there's been great questions in the chat, and it's not my intention to skip over any. There is a great question that came through about accessibility also when it comes to folks who are hearing or seeing, and that makes me think about, as a peer respite operates in a community and more folks hear about it, want to be involved, I imagine there's also things that have maybe been surprising or you didn't anticipate, or where you had to build out in a different way. We talked earlier about making sure that things are accessible in terms of mobility. Are there any other things that have happened related to the pandemic or not, but that were unexpected situations in your respite, and how did you work through those? Go for it.
Yes. We had someone who stayed with us who was under a guardianship, and their guardian resigned, and they wanted to leave the state. They couldn't leave the state. So a lot of our peer respite advocates, myself included, supported this person through this guardianship case. It took like more than the usual amount that a person would normally stay at our peer respite, and we were able to extend and extend and extend well beyond our maximum capacity. So this person stayed with us, I think, for close to 3 months, and we were able to, adjust a temporary guardianship situation with someone that they trusted, because the guardian who had resigned still had legal control over this person's life. I think people don't recognize that, like even once that happens, that's a circumstance. So that was hard, and throughout the pandemic, we've been doing our unhoused peer support project, which is, there's a 1.5 mile stretch of Boston, right, that is an unhoused encampment. It's off of Mass and Cass. Often it is referred to as Methadone Mile. We've been trying to change that name to Miracle Mile, and we're working on a documentary about this and all this. And we've been supporting people in those circumstances. There's been collaborations with tiny house projects and many other things that are happening in Massachusetts. But all of that's to say that we've had a lot of interesting situations, but I'd say the most interesting is probably that guardianship circumstance.
So we have had a couple of folks that were fleeing sex trafficking. One directly was fleeing, and somebody that we know very well recognized this person in distress on the street, and was able to say, we need to go, and I know where we need to go. And it gives me goosebumps just to talk about it. And the person showed up at the respite. And there's a lot that goes along. If you've never worked in that community and understand the safety risks and the really serious things that need to happen, there's a lot that needs to happen under those circumstances. Tamala, you're shaking your head, yes. And another person that was in an underground temporary space because they did flee sex trafficking. Both of these people were abducted from other states and had been involved in sex trafficking for many years and found a way out. So those are a couple of those types of, we get situations all over the map. I will tell you, we've had 2 incidences, I will say, at our respite, and both involved guardians. Interesting that, Vesper, yours involved the guardian as well. In both scenarios, when we reflect back at what happened, we were able to realize that while the person said they wanted to be there, they felt pressured by their guardian to give the guardian a break, rather than them being there for their own purpose of respite. And we did not follow our own process, right? Sometimes, like, our hearts are just so big and we want to love and support and engage and do all of these sort of things, but we can miss some really key pieces of information that we needed to have, or just some of those signs that we needed to have. So 2 individuals landed in our respites that both felt pressured to be there, and both scenarios created some safety risks in the space. And so we have learned a lot from the guardianship issue, and are still learning, how do we navigate when folks have a guardian, that they are truly there in a non-coercive way and want to be there.
Yeah, I would echo that, where there have been people that have been voluntold to call the respite and come in, and it's not a comfortable situation for anyone. And so we've had to address that. And then the domestic violence issues that come up that aren't at the surface, that my staff have been good at, figuring out, as well as the sex trafficking work, has probably been the bigger challenges that we faced. One other challenge we face is, unfortunately, a hospital that doesn't understand or care sends people to us literally physically ill. Not sends them to us, but they call us and they say, "Can I come to your respite?" And we bring them in, and it's they're in horrible physical shape. So we go to another hospital. We work with a more friendly hospital somewhere else when that situation occurs. But that's another thing to just be aware of, is where they're coming from. Are they volunteering to come in? You may not get that all the time.
Thank you so much for sharing all of those stories, that it speaks to and makes me think of the complexity that we all have in our lives, but often when we're coming into a particular kind of system or service that might have been traditionally siloed, that there's not always even an awareness. I mean, I think we all know in our person, like in our lives, that human lives are complex, and we have families, and we have histories, and we have situations and things we lived through. But that when the doorway is very narrow, or the scope of the support is very narrow, you miss all of this. That I know there were some questions earlier about, you know, are your respites seeing folks who are coming maybe for the first time or are coming once? Or do you see folks who are utilizing the respite? Cherene, you mentioned the idea of kind of anniversaries or using the respite in a preventative way, maybe because there are all of these dimensions of stress or overwhelm or limitations that folks are navigating. Could you speak with that a little bit about what you see of respite as prevention, or respite as something that becomes a big part of someone's life? Or do you have folks maybe who come once and then don't have to enter this, so you know, the mental health service system in a way? Could you speak a little bit about that, those pathways?
Yeah, I mean, I can say this much, that we've had folks who have returned, but more often than not, that's like a handful of people. And I think that's because we become like a trusted resource where they come back again. And I would say that more often than not, if people don't end up returning to the respite, they're usually still engaged in our peer support groups that we offer online or in person, or they call our peer respite warm line, or sorry, peer support warm line, or they've taken our certified peer specialist training. They might be working in peer support. They might be doing something new. So usually people continue to be involved in our community in some way. And if they need support and they don't necessarily want to go into the respite, they've requested mobile. I've seen that numerous times. Yeah.
Yeah, I would say the same, you know, as Vesper says, and we have the houses become natural warm lines anyway, so they don't always have to come back into the house. But you know, we welcome folks when they come back. It's good that we can continue that journey, you know, together. But they are mostly involved in all of our other services, so it's nice to, you know, keep that continuum going for them.
Yeah, and we also have a 24-day, 7-day-a-week countywide warm line that we operate. And, you know, we have, I don't know, 30 employees on that line. And so at any time, as frequently as somebody needs, they can call and talk to a peer supporter. So I think that has been helpful. In addition to, as you both were saying, being a part of any classes and groups and activities, we operate 95 different groups and activities every month in our community and online. So there are a lot of access points. Here would be the exception for us. There are people in our community that are on a do not serve list, whether it's a litter list or a in people's heads list, because they are considered to be too dangerous, too unwell, too complex of life experiences. As an agency, we are the safety net in our community for anybody to be supported no matter what. So your history is irrelevant to us. There's no diagnostic criteria and there's no referral. That means that we end up very frequently have been kicked out of every service or walked away from every service. We are the only game in town, kind of like Vesper, you were talking about that rural area with the respite. That's the only option. We as an agency are the only option for many, many, many people in the community. That means for our respite, it's either jail, hospital, which you'll end up in handcuffs and shackles anyways, or our agency. That means that if you have to have repeat stay at a respite, we will do that all day long. If it means that you have access, supports, and an opportunity to reimagine your life that does not end up in handcuffs and shackles. So we do have a handful of people that come back to the respite for a variety of different reasons. We've also had school teachers that have planned a respite stay during a break. You know, can you imagine being a teacher right now coming off of COVID? And for folks that have those types of positions, to have police show up or mobile crisis show up or to be hospitalized is a career ender for so many people. So to have a warm line that's anonymous and have a respite where none of that is going on a record becomes an accessible option for people that are first responders, having other types of roles, and they'd be concerned about other type of space.
Thank you all so much. The dimensionality that's just erupted, I think, in the last couple of questions has been really revealing and really exciting, of understanding, like, when you have a peer respite in your community, it unlocks all of this other knowledge and skills and support and understanding of what's going on in our communities. I was thinking about the word engagement. There's a lot of focus on how do we engage people with services? How do we keep people engaged? And then I thought of the idea of a gauge is literally, right, it's a way of measuring. And there are different gauges. There are different sizes of gauges. So the whole piece of this engagement isn't just getting someone from point A to point B, but it's for them to be able to make the choice of, you know, it sizing up or sizing down, of going over here. It's that ability to suss out and measure for yourself, like, what's the right, am I a teaspoon today? Am I a tablespoon? Am I a cup? Am I a gallon? Like, what do I need so that I can move forward in my process? If I can bring us together maybe for a last question, which is thinking about young people, whether we're talking transitional age youth, folks from that sort of like 18, 16, 14, and into late 20s or early 30s, or folks who are younger. I know in Maryland, there's been efforts about being able to lower the age of consent for behavioral health services, recognizing that we know when we want or need support, and that home may not always be a safe place in various ways of understanding safety. Could you talk about where you see the role of a respite now or in the future when it comes to young adults who may not have all of the same legal rights and maybe dealing with those guardianship issues, but who certainly need support, or maybe are not housed or have been kicked out of their homes, and really could benefit from something like a respite? So respite for young people, what are you seeing? What are you feeling?
We're fortunate that we have a couple of housing providers that provide not necessarily respite for the youth, but places for the shelter for them to go to. And their houses, they're not typical shelters that you would think of for the youth. But we did design a youth and family respite in Brooklyn that's been operating and pretty successful. And so we're now bringing that up to our area to get that set up. And we want it to be, you know, definitely respite for the youth, but also respite for the families. So we're building family rooms so that the family can come and stay together and work together on an open dialogue and on their situations, and trying to come to resolution of all living together and you know, living well together.
The hardest part, oh, go ahead, Vesper.
Sorry. I was just gonna say that, like, it's interesting when we talk about young adult peer support, just in the way of, like, I think when people think about young adult peer support, they inherently think it has to be more clinical. It can't be as autonomous in the same way as it's but I beg to say that it's a transparency first model of like, yes, I'm an adult with a certain level of autonomy. Even if you are a young adult, if you are above the age of 18, you have different legal rights, right? So we have a young adult advocacy training that talks about all of this and how we support young adults. In terms of a young adult respite, that is something that we're interested in. I think similarly to what you were talking about, Steve, we've been working with a youth shelter and a few other young adult environments, but like, yeah, we've been looking at that model and seeing how it could work. I do like the idea of family and open dialogue as well.
We have been asked to open a youth warm line, a youth respite, several things with young people. And here's what I say about it. Number one, anything that's going to be developed for young people has to be developed by them. I'm a 50-year-old, almost 50-year-old woman who came into systems when I was 13, but that was what, 37 years ago? And there's nothing I'm going to be able to create that is going to be relevant to young people if they're not the ones that are creating it. And they're the designers and the leaders of whatever it ends up looking like. That right off the bat creates a rub, because I can't talk about anybody else's states or anybody else's community, but there is still a very, very large degree of paternalism when it comes to young people. And people need to be told what to do. They need to be managed. They need to be monitored, which is very, very different than what a peer run organization is and what our values are rooted in. And so what I keep coming back and saying, it's just like we do with all of our funding, these are the conditions under which we would accept funding. Number one, it is truly youth developed, led, designed, supported. Number two, as a system and a community, we have to wrap our minds around youth voice and youth leadership that does not default to paternalism and parental choice and clinical decision-making over the youth. If we do that in this environment, in an unlocked, non-coercive environment, it's no longer non-coercive, but the unlocked part is going to be a problem. Because just like the adults we have with guardians, there's going to be a pressure to be there and to again have somebody else have control and power over you, which is the recipe for safety issues. That's, people ask, like, how do you keep a respite environment safe? There's no there. We don't have any power over somebody. There's nothing to argue about. There's nothing to fight about. We are there as supporters, right? So it's a very different environment. If that were going to be changed in a peer-run respite, it would have to be designed very intentionally. And that's where I would be concerned about safety issues. So for me, it's about our community perception and our community embracing it, less about whether we should be able to do it for young people and with young people. That's a no-brainer to me. But can the community hang with it is the question for me.
Phenomenal. I just cannot thank you all enough for taking so much time so generously out of your very busy lives to come and talk with us about Peer Respite today. You just have been so transparent and given us all a lot to think about the possibilities and about, how do we stay true to creating Peer Respite the way that it should be and not get pulled into, how do we embed the yes and say no? Right? Like there's that piece of it. Can I ask, if you all had a sign on your desk or on your wall or a rock in your pocket with a phrase engraved that really is the thing you come back to when you're faced with all these decisions about expanding, replicating, managing peer-run organizations that offer a respite, is there a mantra or a phrase or something that always centers you in your decision-making about how to move forward? Just, if you could put it on a bumper sticker, what would it be?
My favorite is, it takes a discipline of hope. You cannot imagine or continue any of these ideas without hope. And you might feel it is hopeless, right? And it might be actually hopeless, right? But there is a level of what you may need in order to imagine a world that is different than the one we are in. And in order to do that, you do need a discipline of hope.
Our mantra for the organization is recovery. Hope greets you at the door. Recovery is the expectation. But my staff have given me a little plaque. I was just looking for it. Somebody took it. They keep taking it. Never quit. That's what they've, and that's what it's been here. It's just never quit.
The word love we use every day, all day long. We have it in our environment. We do everything through love. And if we do it very genuinely and authentically, through love, you can't go wrong. Even the missteps are okay if we're doing it authentically. But I love the quote, I would prefer beautiful chaos over ugly perfection, right? It tells our team, take a risk, and it doesn't have to be perfect. It tells us that we are all flawed as human beings, and that's what makes us beautiful and gorgeous. And it means that we have to take risks as an organization and know it's not going to be perfect, and that's what's going to make it perfect.
To practice a discipline of hope through beautiful chaos and to never give up.